Hola, buenas tardes a todos. Boa tarde, good afternoon.
Hello and a good afternoon to everyone. Welcome to our webinar on combating ageism in health systems. Thank you very much for being here. Before I give the floor to Dr. Amalia Del Rego, the head of the Unit on Health Services and Access and head of the regional team of the incident management team of PAHO, I want to introduce today's agenda to you and give you some guidance and considerations to bear in mind during the webinar. This webinar will be transmitted in 3 languages, English, Portuguese, and Spanish. Make sure that you are connected to the interpretation channel that you wish. You can find the bottom bar of your Zoom screen to find the interpretation function and click there and select the language you wish to listen to.
Bar of your Zoom screen at the icon below. Tradução ao português está disponível na barra inferior da sua tela no Zoom, no ícone em forma de globo. Esta sesión será grabada y posteriormente compartida en la página y en el canal de YouTube de la OPS, en los 3 idiomas.
This will be shared on PAHO's YouTube channel and website after this. Bear in mind that this is an information session and we will not specifically get into questions and answers. Today's agenda will begin with a presentation by Dr. Sharon Inouye on creating anti-ageist healthcare systems to improve care for our current and future selves. Then we will hear from Dr. Emmanuel Gonzalez on measuring health system responsiveness to older adult needs as a strategy to prevent ageism. After that, we will have a panel with a presentation of country experiences. We have representatives of Argentina, Brazil, and the United States. They will be focusing on integrated health services networks to the needs of the older populations. This panel will be moderated by Dr. Mario Cruz Peñate of PAHO, Chile. The last presentation is an example of country-level policy, which will be presented by representatives of the Ministry of Health of Chile. With this, I conclude my introductions and give the floor to Dr. Amalia Del Rego. I welcome you once again, Dr. Del Rego. Thank you very much, Patricia, and good afternoon to each and every one of you. I welcome you to our webinar on combating ageism in health systems. As we know, ageism is a very common practice in our societies, and it obviously manifests itself in health systems. Many of the models of care and the way that services are organized reflect this problem. We know that age-based discrimination can become a significant barrier to allowing older populations access universal health. So we must combat ageism actively. The decade of healthy aging affords us great opportunities to confront this problem. The COVID-19 pandemic, as we know, has disproportionately affected older adults, not only in terms of the high rates of hospitalization and mortality amongst this age group, but also in the way older people have been affected by restrictions on mobility and interruption of essential services. But we also see that it has impacted and resulted in a poor management of other chronic health conditions, has increased isolation, and had different impacts on social and physical health. This is a situation that we have a lot of accumulated evidence to prove. Ageism refers to stereotypes, that is the way that we think, prejudices, which is how we feel, and discrimination, which is how we act vis-a-vis people based on their age. This was made very evident during the pandemic and has been expressed in various ways. There are many examples that we could share with you but I think that this will be the content of the webinar. But the lack of inclusion of older people in clinical vaccine trials, the consideration of lockdown orders, which were very specific to age group, and limits on the use of resources and availability of treatment for older persons are some of the things that you are going to discuss during this webinar. That is to say, the presenters will have the opportunity to share this with you. Finally, on behalf of the regional incident management system in the pillar of health systems and services, in which the health of older people is a comprehensive component of how our cooperation is organized under this pillar, and for the strengthening of health services, I would like to thank each and every one of you for being with us during this webinar. And I hope that you enjoy this opportunity to learn, share, and find out what elements we can use to combat ageism and honestly contribute to health and access to universal health for everyone, including older persons. Thank you very much, and I wish you the best of luck in this webinar. Thank you very much, Dr. Amalia, for those words of introduction.
Sharon Inouye. She is the director of the Aging Brain Center at the Hinda and Arthur Marcus Institute for Aging Research and professor of medicine at the Harvard Medical School. She's the author of the commentary paper published in Nature Aging that inspired this webinar. The link for the publication is available at the chat. I would also like to let you know that the paper has been translated to Spanish and Portuguese and will be available soon at our Healthy Aging page. Dr. Inouye, please, the floor is yours.
Thank you so much. Are you able to hear me? Very good. I just want to thank Dr. Morse, Dr. Vega, Dr. Del Riego, and others for this invitation, and to PAHO. It's a tremendous honor for me to speak here, and I'm so excited to talk about my paper with you, which was very near and dear to my heart. I want to start with telling you a little bit about my background and my journey so you can understand why I came to write this paper. So my background, I'm a physician in internal medicine and geriatric medicine. I specialize in the care of older adults. I currently do active clinical practice, education, training, and research. So I do have aging expertise. I'm also trained in epidemiology and public health, as well as health policy through the Health and Aging Policy Fellowship. I have participated in many healthy aging initiatives globally, including through the National Academy of Medicine's Grand Challenge in Aging and AARP's Global Brain Health Initiative and others. I'm an innovator and a program developer. I try to find ways to improve hospital care for older adults. And I'm also a mother, a wife, a caregiver of my 92-year-old mother, and a brand new grandmother myself, as you can see here. And so these are all of influencing my perspective on ageism. And then I want to say a bit about my personal experience during COVID-19. So I work at a 600-bed long-term care facility in Boston. We lost over 100 residents, 17% of our population in 2.5 months between March and June of 2020. And there were refrigerator trucks lined up outside our building. There were family members wailing in the parking lot since they were unable to enter the building. So you can just imagine what a horrific situation it was. And I know these types of experiences were occurring worldwide. And on a larger level, you know, we witnessed the widespread failure of our healthcare system to deliver adequate or appropriate care for older adults across all settings of care, the emergency room, the acute hospital, the intensive care unit, and the long-term care setting. There were large-scale systemic failures, inadequate PPE and training for staff. It just went all the way across the spectrum. And we also saw age-based rationing of care, as Dr. Del Riego already mentioned, where crisis standards of care were initiated and care was actually summarily denied to older adults based strictly on age. And really, we survived with the heroic action of individuals, but unfortunately, these types of heroic actions of healthcare professionals, public health professionals, and so forth, have a limited and small scale impact. And this is what really motivated me to write the commentary that you've heard about, because I really felt we needed to make large scale changes. And I hope this will present an opportunity, and things like this conference today, this webinar, I hope will motivate these types of changes. And of course, WHO has, during the same period, announced an initiative on the decade of healthy aging, which I think is so important. And the principles of healthy aging for all, I think, resonate with all of us. And these are some of the principles in the report that this initiative needs to be global across all aspects of society. We need to really focus on the interconnected nature of society. This initiative needs to be inclusive, universal, equitable, intergenerational, sustained, person-centered. And these are, I think, the fundamental principles that if we can achieve, we will indeed be able to see a healthy aging for all. WHO does provide many resources, including an integrated care for older people package with guidance for person-centered care and pathways in primary care that I think are going to be very valuable to guide this initiative. So I wanted to start with the definition of ageism that I based my commentary upon. And this, again, fundamentally is age-related discrimination. And this can include both explicit age cutoffs, as we saw in some of those crisis standards of care, so denial of treatment or resource allocation based on age alone. But perhaps even more importantly are those which are not explicitly age-based on a cutoff, but have implicit age-related biases built in, which limit access or create barriers to healthcare. I'm going to talk a bit more about that. And both of these types of direct and indirect age-related discrimination biases operate at both systemic and individual levels across our healthcare system. So how does ageism lead to poor healthcare? Well, it permeates so many areas of our healthcare, and we know it leads to poorer health and increased mortality. This has been very well demonstrated in multiple studies. So both explicit and implicit age-related biases can result in inappropriate or inadequate care or denial of care. It can happen with diagnosis, prevention, or treatment of disease. It can limit access to life-sustaining treatment, as we saw during COVID so dramatically. It can limit access to innovative treatment modalities. You heard the mention of lack of inclusion of older adults in some of the COVID clinical trials. And so denial of treatment based on the fact that it hasn't been adequately tested. This has been widely recognized in cancer and cardiovascular treatments, for instance. It can also result in delayed access to care or inappropriate care. So what are some of the unique aspects of care in older persons that everyone in healthcare needs to be aware of? Well, atypical presentations of disease are very common in older adults. And we saw this very dramatically during COVID-19. In fact, it's been shown that COVID-19 is very often presents with atypical symptoms, not with the classic fever, shortness of breath, and cough. You can't count on those symptoms in an older adult. So it can present just with confusion, falls, failing to eat, dehydration. Those can be the presenting symptoms in an older adult. And if physicians and nurses are not aware, it can be missed. And I think that's in large part what happened at the start of the pandemic, when there wasn't that realization and patients would appear with, failure to thrive, so to speak, and then they were sent back to their nursing home. And that's what happened to create some of the epidemics in our long-term care facilities. Similarly, acute myocardial infarction or heart attack is more likely to present with atypical symptoms, with loss of appetite or weakness, rather than classic crushing chest pain. Adverse drug reactions are extremely frequent and often unrecognized in older adults. Drug and drug disease interactions are very common. And then what happens when we don't recognize that something is an adverse drug reaction is we get into prescribing cascades. It's actually just happened to my 92-year-old mother. She was started on a new blood pressure pill that caused her legs to swell. Then because of the swelling, they started her on a water pill. And it was going on and on until I said, hey, wait, that's the side effect of the first drug. Could we please stop them both and switch her? And so I was able to halt that prescribing cascade. But this commonly happens in older adults, leading to more and more adverse drug reactions. And I think the problem is we need more training and education of our healthcare professionals, specifically in the unique care needs of older adults. I already talked about this atypical presentation in COVID-19. I just want to stress that delirium or acute confusional state is often a presenting symptom. It's the sixth most common presenting symptom, and it can occur without fever or cough in 37% of patients who have documented COVID-19. And I brought this evidence to the CDC, and unfortunately, they still have not changed it on their website under their watch for symptoms. I'm still hoping someday that it may get added to the warning symptoms of COVID-19. So I want to talk for a moment about integrated and coordinated patient-centered care, which is a big focus of the article that you've heard about, because I think it's so important to be aware that this is really the way we provide appropriate care for older adults. We need to try to avoid fragmented care, particularly older adults getting caught up in a web of specialty clinics or subspecialists guiding all the care. And we need to facilitate goal-directed, person-centered care guided by the preferences of older adults and involving not only the patients themselves, but their families and people who have expertise in aging to help conceptualize these person-centered pathways for care. I think we also need to focus on reducing barriers to access to care. And there are many barriers to care built into our healthcare system such that we may not even realize why older adults are not seeking and obtaining the care that they need. And they can be at the patient level, at the provider level, at the insurance and financing level of care. And so really, when we talk about developing age-friendly healthcare systems, I really hope we will focus on looking at these barriers that make it more difficult for older adults to access care. One thing is environmental barriers, for instance, signage or translation barriers, or even hearing and vision barriers that don't allow older adults with physical or cognitive impairments or other disabilities or literacy issues or language problems to access the care that they need. I would really like to see if we could help build digital capacity for older adults so that communication can occur. We learned during this pandemic how important the ability to use a mobile phone or a computer with internet are to access healthcare when things were shut down. We need to think about attending to social cultural issues, including anxiety, fear, and distrust of the healthcare system. It's a real issue, and one I think we need to work steadily on to try to overcome. And of course, we need to involve older adults and their families in coming to the solutions to these problems. So involving family and caregivers is absolutely essential to provide optimal care for older adults. And it's really even more critical for those older adults with frailty and dementia. We need to involve family and informal caregivers to have good bidirectional communication, to monitor treatment and adherence, to have patient advocates across settings so we could provide optimal care and improve our care, and to assure follow-up. We also need to enhance effective use of preventive care. And so we need to address, again, systemic factors that allow and enhance older adults utilizing preventive care. In the US, Medicare covers a preventive visit, what's called the Medicare Wellness visit, every year. It's supposed to be provided for free to all older adults, and less than half of older adults who are eligible access the service. And so this is really something we need to address. So preventive care, of course, differs across older adults versus younger adults. And again, is a very important area that we need to make our patients knowledgeable about, and also our healthcare providers. So things that assume much increased importance are vaccination, exercise, fall prevention, prevention of cognitive decline, adequate nutrition, smoking and alcohol cessation if that's indicated, medication use, education about medications, and attending to home safety. These are just some of the preventive measures that are critical for our older adults. A word about denials of life-sustaining treatment. So you heard about it during COVID, but this is not new. Access to innovative or expensive treatments has been routinely denied to older adults across health systems globally. So things like hemodialysis and transplant have been denied even to very healthy 70-year-olds, for example, expensive cancer treatments. And then we heard about the COVID-19 treatments. I think we need to avoid rationing by age alone and think about the appropriate criteria for, limitations to these expensive therapies that are fair and equitable globally. And I think we need to utilize, as has been recommended by several groups, interdisciplinary groups that include geriatric experts to help with this complex decision-making and who should get access to care, particularly if it's very expensive or in times of critical shortages or humanitarian crises, to make sure things are fair and equitable. So a word about exclusion of older adults from clinical trials. We heard that happened during COVID-19. It is a long-standing problem, and I am working very hard with multiple groups to try to see what we can do to address this. And we need to educate clinical trial organizations, but also we need to address barriers to participation, to train staff, to develop alternatives to internet-based participation, to provide transportation and flexible schedules, to involve proxies and family members, and to minimize exclusion for things like stable comorbidities or hearing impairment. And definitely aging experts can help with creating very efficient enrollment designs, train staff, and assure equitable access to new therapies and vaccines, because that's really the issue about inclusion. You want to make sure that ultimately everyone can benefit from that new treatment. And then we want to think about long-term care, providing an integrated system that can care for older adults across the lifespan, and that integrates both community care and health care in a very seamless and effective way. And really to have the healthcare system working with the social care system and community care and with public health, with the common goal of maintaining functional abilities across the lifespan. So I think in conclusion, we realize we're all interconnected as societies and individuals globally. No one is an island. And we need to improve healthcare for older adults. This will help everyone. If we provide good care for older adults, we provide good healthcare for everyone, including our current and future selves. So thank you so much. I really, again, appreciate being here. Thank you.
No, thank you so much, Dr. Inouye, for your presentation and for being with us today. En seguimiento a nuestro seminario, les presento el Dr. Emmanuel Gonzalez.
I now introduce you Dr. Emmanuel Gonzalez, who is a geriatric specialist and expert from the Toulouse Gerontopole Research Center in France. Emmanuel, you have the floor. Hello, and thank you very much, Patricia. Greetings to everyone, and thank you for the invitation. Is my sound coming through clearly? All right. Okay. I will now share my presentation.
Ustedes pueden ver la presentación ahí.
Can you see my slide? Yes, we see it perfectly. All right, then. The idea of this presentation is to establish some guidelines regarding how measurement and monitoring can help us fight ageism, specifically monitoring the response capacity of the health system to the needs of older adults. Key messages. One is, can measurement and monitoring help fight ageism by giving evidence of the injustices that exist in access and coverage and impact indicators, all based on age? And there are two very specific areas of measuring equity and also effective coverage.
On this slide, what I'm showing is that monitoring must be tied to your healthcare system strategies. That is to say that the data that come from monitoring indicators may be used as a guide to see which gear of the system must be tuned in order for the system to work more smoothly or better, or what kind of adjustment need to be made. So this is the monitoring framework for universal health that has been used as a basis on some of the exercises that we developed, and it can be tailored to the specific needs of older adults. Now, what do we mean by having a healthcare system that is responsive? In the early 90s, or the 2000s rather, we kind of ranked healthcare systems based on how responsive they were. This approach was heavily focused on user satisfaction.
Recientemente, en este año, se publicó una revisión
Recently, this year,
conceptual sobre
a conceptual
qué es la capacidad
review
de respuesta.
was
Y en
published
esta diapositiva lo que quiero
regarding what
llamar su atención
responsiveness means. And what I wanted to point out from this slide is that user satisfaction does play a significant and direct role in assessing how responsive a system is, but there's also a social dimension that focuses on the population, and it may be used as an accountability mechanisms. So we need to know what kind of mechanisms our healthcare systems use in order to respond to the needs of our older adults, not only as the experience that people have when they come to receive healthcare service, but going beyond that and going to families, communities, and society in general. Now, this is the conceptual framework that we developed in our healthy aging group together with Enrique, Patricia, and some other colleagues that were part of this effort for quite some time, also country colleagues, in order to have this framework that can give us an idea of what indicators are better to measure how responsive our healthcare systems are. And I would like to echo what the doctor that spoke before me mentioned when she talks about barriers. It is very important to identify barriers to access because in this population, these barriers may be very specific. As an example, the countries where we use a tool, we found that the most frequent barrier had to do with transportation, be it because the older adult could not pay for their own transportation to go to the healthcare center, or there was no transportation available, or the way in which the jurisdictions were laid out that resulted in a mismatch in which the population was distributed. Now, this is an example of how at the end of the day, we ended up summarizing the findings from what we saw in some specific countries. This is an example of what we did in Chile, where we found a lot of healthcare responsive indicators, and we grouped them together using the framework for monitoring universal health, and we divided them into strategic actions, which is what you can see on the top left.
También atribuimos un color.
We also used color coding to identify the indicators that were highest priority, and which ones in green, for example, are the ones that are showing that healthcare systems are actually responsive. And we had a small box referring to long-term care, which is a very important aspect of how to assess responsiveness in our healthcare systems. So in the countries that were under review, we found the following common situations. For example, periodic evaluation of functionality, for example, preventative type of consultation, including some kind of measurement, be it, basic daily life activities or measurement on physical capabilities, is acknowledged in some of the healthcare systems, but coverage is not quite there yet. There is also a gap in terms of human resource training for older adults. So they need to be able to identify their needs and resolve them. We also have this polypharmacy is what we call it. Currently, we're not having large-scale mechanisms to avoid this cascading, prescription cascading or over-prescription, which we call polypharmacy. In some literature from the United States, we found, for example, that something as simple as installing a piece of software can enable a doctor know if there is a case of overprescription. Also, out-of-pocket expenses for health. If we measure surveys globally, we can estimate this out-of-pocket spending for at least one older adult and compare it to out-of-pocket expenses in health in those households where there are no older adults. And we always find it that whenever there is an older adult in the household, these out-of-pocket expenses in health are significantly higher. And unpaid work is also related to care, right? Is very high because there's not enough, there's not a good offer or supply of long-term care facilities. So let me go back to our key messages in terms of how measurement and monitoring of indicators in it can contribute, eradicate ageism. It can indicate equity, for example, by showing indicators or markers by age group, because there are certain health conditions or out-of-pocket spending, like I was saying, or some other impact indicators that should not be different between older adults and younger people. So if we show that gap or that mismatch in equity, we could make it more visual and more explicit. On the other hand, we have effective coverage, which means listening to the needs and preferences that older adults have, which is key when we do these conceptual reviews of responsive rate. It always involves listening so that we can have a better idea of what the older adults themselves are saying their needs are. An example is recovery time functionality after having, for example, hip replacement surgery. And there's some data from Chile showing that, for example, it is estimated that I'm talking about wait time before hip replacement surgery. It should be 140 days, but it's more like 240 days. On the other hand, in terms of effective coverage for cataract surgery means to have enough vision after surgery. It's not enough to perform surgery, but then see how much vision improved. So having effective coverage also reflect how responsive our healthcare systems are. So here's the difference between coverage and effective coverage. The ones that receive surgery, who can go back to seeing and who cannot. Here is a list of sample indicators that will be published on an article that is about to be published on this work of indicators on responsiveness. Thank you very much.
Muchas gracias, Emmanuel, por tu presentación.
Thank you very much, Emmanuel, for your presentation and for showing how important it is to have data from older adults and monitoring this age group. So thank you so much. And now moving on with our agenda to talk about country experience, I would like to recognize Mario Cruz Penate, a physician and advisor in healthcare services in Chile, and he will introduce our panelists and be the moderator for this session. Thank you so much, Patricia, and good afternoon, everyone. It is a pleasure for me to be here with you today. As we have heard, ageism or age-based discrimination negatively impacts our healthcare systems and results in poorer healthcare outcomes. So we're going to talk about what kind of practices can combat ageism in hospital services, primary first level of care, and long-term care. Special greetings to our panelists today. Each one of them will have 10 minutes to give their presentation, and we would very much thank you in advance for sticking to this time frame. Without further ado, now I will introduce the distinguished members of our panel. First of all, we have Marcos Escobar, a senior officer of program from the Joint Hartford Foundation from the United States, followed by Ms. Gabriela Dorigato and Dr. Carlos Engel, both working at the Social Medicine Secretariat from the Ministry of Public Health in the province of Salta, Argentina. And finally, we're going to listen to Dr. Patrick Worshall, a geriatrician from the State University of São Paulo, Brazil. Thank you so much for your time, and go ahead, Marcos.
Thank you very much, Dr. Cruz Penate. I will share my screen and begin my presentation. Thank you. One moment, please. Okay. Thank you very much. It is a pleasure to be here with all of you, and I want to thank PAHO and the World Health Organization for organizing this important session and this important topic, and really appreciate the work, particularly the WHO has been doing on ageism, putting out the global report, putting out information related to interventions that actually can reduce ageism and its effects, intergenerational programs and others. So this is critically important. And today I'll be talking about, particularly in the United States, how one initiative is doing what we hope what Dr. Inouye was describing around person-centered care that meets the needs of older adults and reduces ageism. I am Marcos Escobedo, and I am Vice President of Communications and a Senior Program Officer at the John A. Hartford Foundation. Next slide. A little bit about the John A. Hartford Foundation. We're based here in the United States, in New York City. We fund across the country. Our mission is to improve the care of older adults. That has been our mission since the 1980s. And today we organize our grant making and our work in 3 priority areas. We try to create age-friendly health systems, which I will talk about in a moment. And those includes connecting to public health, social care, and making sure that all the needs of older adults are met to live healthy older lives. We support family caregivers of older adults, and we work to improve serious illness and end-of-life care. It's been mentioned already, the definitions of ageism, and that is important. Research that we have funded have shown that it is absolutely critical to define ageism to a public that largely does not understand it. So I've chosen the WHO definition here that's been described. I will reiterate what Dr. Inouye noted about this can be at multiple levels, at systemic and individual levels, both explicit and implicit. And one interesting point is that ageism can actually be turned inward to yourself, that ageist views can actually be harmful to yourself as an older adult, and something to be thinking about. We've talked about how ageism manifests in healthcare. I wanted to highlight these particular instances of dismissing treatable pathologies as features of old age, or the converse, treating natural effects of aging as if they are a disease. We've talked about communication is impacted by ageism. We have seen and can have documented that clinicians with older adults in the room with a family caregiver will talk about that older person instead of with that patient. Elder speak is a particular problem that's been studied here in the United States, and it is a way of talking to older adults in a very demeaning way, as if they were children or babies, and that produces poor outcomes. And at the macro level, you've heard Dr. Inouye and others talk about issues related to shortages in specialization of geriatrics and in the exclusion in trials and research of older adults. One quick story from our president, Dr. Terry Fulmer, who sends her regards. She talks about her Grandpa Frank, at an example that just happened last year where she saw her Grandpa Frank. He said his leg was bothering him and he was having difficulty walking. When she asked, well, what did your healthcare provider say about it? He said, oh, the clinician just said, oh, you're just getting older. It turns out he had a fracture. He had a broken leg. After he got appropriate care, he was able to walk again. But that's an instance of ageism resulting in inappropriate treatment, not treating really Grandpa Frank. So as you all, I think, are well aware of, there is a movement around the world to create an age-friendly society for all of us as we age. And we thank again the WHO for beginning the age-friendly cities movement that's now global, AARP in this country taking on age-friendly cities, communities, and states. At the end, I will briefly mention work that we've done to combat ageism through an initiative called Reframing Aging. We have worked with community-based organizations through an Aging and Disability Business Institute at the National Association of Area Agencies on Aging. That is just making sure social care needs are met. I will be talking today about age-friendly health systems introduced in 2016 and into 2017. And we've also have a major initiative around age-friendly public health systems. All of these, including universities, employers, are working together to help create an age-friendly world that can reduce ageism. And I encourage you to visit agefriendlyinstitute.org for more information about that. I will specifically talk about in this country how age-friendly health systems, a specific initiative, is helping to reduce ageism. Together, we are building a social movement so all care for older adults is equitable, age-friendly care. What does that mean? It means it's guided by an essential set of evidence-based practices known as the 4 M's, and I will talk about them in a moment. It causes no harms because we know that one of the attributes of our health system is that older adults are disproportionately harmed by healthcare in healthcare. And most importantly, age-friendly care is focused with what matters to the older adult and their family. It is person-centered and driven by goals. The good news is we have had tremendous success for years, for decades. We have been trying at our foundation to support the delivery of evidence-based practices. And it's amazing how we know what to do, but often we don't put that into practice. Well, with this initiative, we are spreading quickly. We have over 2,300 hospitals, primary care practices, convenient care clinics, and nursing homes that have joined the movement, and that is growing every day. So this is across settings, and we think this is taking off in a big way. It's based on the 4 M's framework. Why this has spread so rapidly across the country, in part, is because we have taken the best evidence available from experts like Dr. Inouye and others and geriatric care models and distilled them down to the essential vital few elements known as the 4 M's framework that are about reliably being delivered to older adults across all care settings. They are focusing on what matters to that older person, their specific health outcome goals and care preferences. This is, of course, needed at end of life, but this is about all stages of life. Medication, as Dr. Inouye so eloquently talked about, adverse drug events, incredibly important. The 3rd M is mentation. Also, Dr. Inouye mentioned delirium, that acute state of confusion. Along with dementia and depression, we have evidence-based screens and practices that can address the state, the mental state of older adults and ensure better outcomes. Finally, the 4th M is mobility, ensuring that older adults move safely every day, that they're maintaining their function. This is exercise, this is activity, making sure that older adults are achieving what matters to them. These are important because they do matter to older adults. They are based on very strong evidence. They reduce implementation and measurement burden for clinicians that are busy, that have many priorities. This provides a framework, again, to reliably deliver to all older adults in all settings, these most essential elements of care. Within the initiative, there are best practices and resources provided to clinicians and teams to help deliver this kind of care. All of these are related, the 4 M's, they are a set and they do impact on key quality and safety outcomes. So how does this address ageism? We believe it meets the unique needs of older adults by increasing the visibility of the older adult population in healthcare, by reliably delivering evidence-based care through this framework with the tools and best practices provided through the initiative. It can reduce under and over treatment. It can avoid treatment based on biases that might be implicit among clinicians against older people. It also goes a long way towards addressing the issue of a lack of specialists in geriatric care. By providing this framework and the basics of good geriatric care, we are suffusing the health system with aging expertise and reducing ageism. And of course, as I've mentioned, this is about respecting and honoring older people's preferences and values. I do want to mention quickly that equity has been talked about by the prior speaker, and ageism is an equity issue. Race and ethnicity also contribute to disparities and a lack of equity in healthcare. And our age-friendly health systems has put equity, and in particular racism, at the center of their work. We collect data on the 4 M's care delivered to older adults, stratify by race and ethnicity, and take follow-up actions to improve equity among older adults. And the last thing I will note is that reframing aging, I mentioned earlier, is something to be aware of. It was based on research here in the United States and is culturally specific to us, but it provides, again, tools and resources for those of us in the aging field to better talk about older adults and aging issues in more productive ways that counter ageism. Please check out reframingaging.org for more information. And finally, visit ihi.org, age-friendly, to learn more about the 4Ms and how you can implement in your system, in your country and region. Australia is doing it. Countries in South America and Africa are doing it. You can too. I will stop there. Thank you very much.
Mario, tu micrófono está cerrado.
Mario, you're muted. My apologies. Thank you so much, Marcus, for sharing with us the work that the Hartford Foundation is doing and highlighting the importance of developing competencies in the healthcare system in order to make healthcare provision to older people more relevant, and as well as this framework on age-friendly healthcare systems and your 4M strategy. And with that, we will now give the floor to our presenter from Argentina. Go ahead.
Hola, muy buenas tardes. No sé si pueden tomar.
Unfortunately, the sound.
Perfecto. ¿Me confirman si visualizan bien la presentación?
Can you see my presentation? Could you switch to presentation mode, please?
Ahí está. Perfecto. Bueno, muchísimas gracias por la invitación.
Thank you. The sound is very bad. We don't believe his microphone has been set up.
Soy secretaria de Medicina Social en el Ministerio de Salud y queremos contarle una experiencia que desarrollamos en Salta para contextualizarlos. Salta es la provincia, Osuna es la provincia.
Salta is a province in the northwest of Argentina. Its location is strategic because it's close to Bolivia, Paraguay, and Chile. It borders 6 provinces, and we believe it's one of the most beautiful provinces in our country. The aging rate is 10%, and the city is in the Valle del Lerma.
1,000 personas. Y su red de centros de atención primaria donde nosotros nos desenvolvemos.
In the primary healthcare center where we work, we have about 62 healthcare centers. A lot of the colleagues that spoke before me have mentioned that there's not enough training, lack of equipment, and the need to work on healthy habits and to have systems that focus on people's life course and NCDs and age-related diseases. We realized that there were access barriers for older adults that limited their engagement. And that is why we developed this project, whose purpose was to improve the quality of care that older adults received in the healthcare centers. We try to make our healthcare systems more responsive to their needs and values. And these are some of the specific objectives: to improve access, train healthcare team members at all levels, administrative staff, professional staff, cleaning staff, and community healthcare workers that go out to the field and engage with these people. And we also thought that we had to develop community-based strategies focusing on promoting active aging, and on the other hand, provide support to family caregivers. So we had this project focused on three big areas: to improve access, to also focus on training, focusing on management of chronic diseases and giving updates on age-related conditions, and also perform community actions such as self-care and support to family caregivers. We are sharing once again what the main items of our project were. There was a starting point when we wrote this up, and before being selected by our national Department of Health, we saw whether there was anything on age-friendly documents, and we found this age-friendly primary healthcare centers toolkit from 2008, and we just improved from there. Like I said, this was our starting point. Here are some pictures to show what our healthcare centers look like. You can see some physical barriers to access. There's no ramps, sidewalks are cracked, and that makes it difficult for older adults to access. Now, what did we expect from this project? Well, to improve care, to strengthen the team ties, improve community support, provide support and counseling to family caregivers. These are the agencies that were part of this, the Ministry of Health, and also a benchmark hospital, a signature hospital, because it has geriatricians as part of their staff. And so we focus on all of this training, workshops with the administrative staff to show them how to treat older adults, also trying to schedule appointments and try to step away from the walking modality that is what they usually go by. Also giving priority to appointments to older adults, make directors more aware, buy supplies that improve their health, supervising their infrastructure, and where possible, we made certain repairs. For example, we built ramps, we introduced improvements in waiting room or holding support bars in the bathroom, etc. Where these are pictures of all of these activities. We have the architects here that came to take a look at the centers. Here's Gabriela delivering supplies, consoles and different types of things so that we could perform these community activities, workshops with the admin staff. So we pulled them away from their desk for a couple of hours and we gave them awareness training on what aging was about and how to appropriately treat an older adult. To conclude and then give the floor to Gabriela, who is the director and whose experience I'd like to hear, that we had strengths and opportunities. The team was motivated and they were highly engaged, but we also have weaknesses and threats. The healthcare structure tends to revert to the way of doing things in the past, and that's what we have to keep an eye on so we can make sure that these projects move forward and we don't fall back. We were able to have referral offices, changes in the model of care, but undoubtedly the biggest challenge was to sustain this service and move towards a model that includes older adults as the main actors in any visit. This is the challenge, and we believe that this experience may be relaunched and updated with the tools that we have available today. We need to continue with community activities and maintain the building improvements so that we can minimize barriers to physical barriers to access. And Gabriela, with that, the floor is yours.
I thank you for the opportunity to participate and to share this very successful experience Carlos and I had. And we can say that it was able to be maintained over all of this time. Even while I'm no longer director of that center. Today, I'm at a decision-making and management level, which also allows me to take these lessons learned to the provincial level, access to health, inequity in our province. In our province, we have a lot of indigenous communities. So ageism isn't the only thing, the only source of discrimination. There is also discrimination based on ethnicity or origin and poverty. So we need to resolve health problems, which are often very straightforward. This has been a successful experience that allows us to bring health to a population that was deemed to not have the right to participate in health at their community center. The health center is in charge of a community, and the community of older adults did not believe they had the right to participate or receive care at the health center because they felt that that would be taking away health care from a child or a pregnant woman. For this reason, if we have protected visiting hours for them at an hour that is convenient to older adults and changing the timing of the public transportation, and we got the bus to stop at the door of the health center so that the older adults could easily access that care. I think at a certain point we were rather visionary. And for me personally, it was very useful in terms of bringing this concept of health to many other areas of the province. So I continue to be actively engaged with Carlos in all of these proposals. And today, what we're trying to do is through the province's primary health care system and through COPE, which is to offer other opportunities to older adults. And I also would like to share, as happens to everyone, experiences that we have in our own families get us to be more committed, more passionately committed to fighting ageism. I can tell you about my own experience, like Dr. Shannon did. My father died alive because my father had cancer, but up until 1 month before he died, he was able to play golf and to carry on a normal life. And that's what I want for everyone in our province. Thank you. Thank you very much, Gabriela and Carlos, for that sharing that very interesting experience. It shows us how, starting with an educational intervention with the health system, an entire movement was created. We know that strong primary health care makes every difference in terms of ensuring the right to health in a system that tries to move towards universal health. And if you place older adults at the center of a gap analysis, we can see how, with the available resources and by mobilizing the community, which is always very close to primary health care centers, you can make a difference in terms of responding to the needs of older adults. So thank you very much once again, Gabriela and Carlos. We will now hear from our third panelist. Patrick, you have the floor.
Patrick, no te escuchamos. We cannot hear you.
Sorry, Patrick, we cannot hear you.
No, can you hear me?
Yes.
Perfect. Thanks for having me here. It's really exciting to see so many people involved in the discussion of ageism and age-friendly systems. In the next few minutes, I would like to share with you some thoughts concerning the long-term care sector. The need for long-term care is expected to increase significantly in Latin American and Caribbean countries as the population aged 18 and over is growing. We have been witnessing a substantial growth in the number of age-friendly communities in our region, And accordingly, the progressive adoption of technological advances has also changed how we deliver care, facilitating the opportunity of aging in place. The adoption of ICOPE guidelines developed by the World Health Organization provided an evidence-based approach to improve primary care for older persons. But then we have long-term care. Long-term care facilities are likely to play a continuing role in caring for the most vulnerable and frail older people, particularly those who cannot live independently. They are called by different names in different countries, but they mainly provide 24-hour personal support, including help with activities of daily living and rehabilitation, and frequently play an essential role in the end-of-life care. They may or may not be staffed by healthcare professionals, depending on local requirements. And in developing countries, however, the sustainability of long-term care sectors depends upon policy and economic decisions. Low and middle income countries are at different stages of preparedness for dealing with the needs of long-term care sector. Despite macro social, economic, and health advances, access to long-term care facilities and the quality and affordability of care do not seem to have improved globally. Older people living in long-term care facilities have been disproportionately affected by the COVID pandemic, and despite considerable variation, mortality rates in long-term care facilities accounted for more than 70% of all COVID deaths during the first and the second waves in some countries. The ineffectiveness or non-existence of public policies targeting the long-term care sector is evident in many low and middle income countries. The inappropriate use of acute care hospital services and emergency departments is much higher among the oldest olds in places where the long-term care sector is underdeveloped or absent. As in some Latin American countries, in Brazil, there is no federally mandated coverage to support the Asian population in need of long-term care. These facilities are scarce despite the growth of for-profit sector. Public expenditure per older adult practically does not exist. And in Brazil, it's estimated that at least 6,000 formal long-term care workers are needed to fill in this gap. Disregarding the peculiarities and internal processes of long-term care facilities could lead to institutional violence and mistreatment. Without an appropriate public policies, ageism may perpetuate obsolete or missing operational rules, which prevent the introduction of best practices for person-centered care and improve the quality in long-term care sectors. While COVID has brought ageism and long-term care facilities into the headlines, it has also provided an unprecedented opportunity to improve health outcomes. In some countries, older residents and long-term care workers were included, for instance, as a priority group for immunization. But however, in other countries, they were regarded as group of lesser clinical vulnerability according to clear ageist criteria. The World Health Organization included access to long-term care and person-centered integrated care as main areas for action during this decade of healthy aging. As Professor Marcos has already spoke, the 4 Aims framework, it's an initiative extremely important to deliver effective person-centered healthcare for older adults. An important component is exactly to assure that those meaningful activities that met residents' wishes are included in their daily activities. The pandemic has not only overwhelmed health systems worldwide, but also placed a spotlight on the weaknesses of national data sets for long-term care facilities. COVID-19 has been a pandemic or a syndemic of inequalities. Among 64,000 residents of long-term care homes, the third-day mortality was near to 30% after COVID, a positive SARS-CoV test. It is not surprising that it took us just a few days or weeks of lockdowns and social distancing to understand how stressful and loneliness and social isolation can be, and how it can impact anxiety, depression, sleep, and physical symptoms. But it remains difficult to understand why our healthcare systems remain stagnated when addressing the same issues with older residents who are locked in long-term care facilities for the last 18 months. Coronavirus outbreaks will probably continue to occur for the following years, similar to other respiratory viruses. And the long-term effects of immunity rates after vaccination remain largely unknown among the most frail older person living in long-term care facilities. In a Brazilian study of preparedness for mitigating COVID-19, difficulties and problems with infrastructures and or resident care were much less commonly reported than those related to maintenance of sufficient stock of materials, workforce, for instance. Adherence to the World Health Organization infection preventive guidance was considered excellent among most of the facilities for most of the proposed recommendations, regardless of long-term care size management. Social distancing guidelines and restrictions remain meant to protect residents of long-term care have inadvertently prioritized quantity of life over quality of life and have worsened the ongoing social isolation crisis among older adults. Governments need to address the pervasive staffing and funding issues and update long-term care infrastructures. Until then, long-term care home decision makers and administrators need to be more open to innovative person-centered practices that can reduce the trauma experienced by residents caused by social isolation. Low and middle income countries should implement policies for long-term care that involve in several aspects of social assistance and health. We would like to present some of the work we have been conducting in Brazil since the beginning of pandemic, particularly related to the Frente Nacional de Fortalecimento AIRP. In Brazil, the Frente Nacional initially created around emergency issues related to coping with COVID-19. The movement has expanded and is currently aimed to promote the planning of actions, articulation, studies, and research for the strengthening of the long-term care sector and public policies for older people. In the beginning of our work, we start understanding the growing of the number of long-term care facilities in Brazil. We found that over 100% increase in the number of long-term care facilities since the census in Brazil. The Frente published a consolidated technical report in the first months of the pandemic in collaboration with more than 104 registered volunteers from different areas. We conducted webinars, educational booklets for managers, for staff workers, caregivers, and family members of older residents living in long-term care facilities in Brazil related to different issues and different themes. And we are aiming now to establish a national data set for long-term care facilities and the long-term care sector in Brazil. Thank you for the opportunity, and I'm ending my presentation.
Muchas gracias, Patrick.
Thank you very much, Patrick, for bringing to the discussion the big challenge our region has to have a true long-term care system and how the COVID-19 pandemic has exposed how much there is still to do and how much we need to cooperate and collaborate like you did in order to provide more resources to long-term care facilities. We would
panelistas
like to thank our three panelists, four panelists, by the way, once again for your presentations, and thank you everyone for your attention. Thank you, and Patricia, the floor is yours.
Muchas gracias, Mario, por la
Thank
moderación.
you so much,
Muchas gracias a los
Mario, for
ponentes
being a
las
moderator of this
importantes
panel, and thank you
experiencias
so
que nos
much to our panelists for your experiences you shared. Now, to have a country policy perspective in this topic, we would like to invite Dr. Silvia Santander, head of the Disease Prevention and Control Unit at the Ministry of Health in Chile, and Mr. René Montes for the older adults at the Ministry of Health in Chile.
No te escuchamos, doctora.
We cannot hear you, Dr. Santander.
Sí,
What about now?
gracias.
Now we're good. Good afternoon, everyone. We are very thankful for the invitation and the opportunity to listen to you in the first place, and also to share some very good news, which is the launch of our national comprehensive health care plan for older adults, led by Dr. René Guzman, who's joining me today for the Center for Control and Prevention, Disease Control and Prevention that I lead. I cannot move my slides. So it's a pleasure for me to show you this today, and hopefully you find it useful. I'm going to go over overview pretty fast. We know that older population went from 524 million in 2010 to over a billion by 2050. In Chile, our demographics and situation is the following. We are in an advanced demographic transition with 65.6 older adults for every 100 young people younger than 15. There's low fertility, low mortality, and positive but slow growth. In 1950, 55% were people over 60, and by 2050, we're expecting to have 33% of our population over 60. According to our 2017 census, we have about 16.2% of our population over the age of 60, pretty much half and half, men and women, mostly women. And as far as the distribution of our country, older adults tend to move to certain parts of the country. Now, how do we get to this advanced demographic transition? Well, low fertility, high life expectancy, and we can see that there's no room for everyone in the future, and I will address this later on. Now, in order to get to this point, we see two important processes. Some that have to do with the socioeconomic aspect, as to say, a significant improvement in the per capita GDP. As we can see here, back in 1960, we had $505 in 1960, and now we're about over $13,000 per capita. So this is a very significant increase. There's also been a decrease in poverty and extreme poverty in our country starting in 2006, 29.1 to 10.8 in 2020. And I'm sure this figure will change as a result of the pandemic, but this is the figure we have today. And the Gini index, which rates equity, in 2017 was 44.4. So good socioeconomic data, but the Gini index is not very good because it shows that there's no equitable distribution in our country. The second significant process that we see in Chile for this transition are highly relevant public healthcare policies. We have seen a significant increase in our national immunization program, so much so that we have managed to populate pretty much all of our elderly population for COVID, healthy checkups for children, which is a very important program, assistance during pregnancy and delivery, and health technologies. All of these lead us to the following impact indicators: reduction in child mortality, reduction in maternal mortality, and mortality as a result of diseases. These indicators lead us to some demographic indicators that I already mentioned: increased life expectancy, reduction in fertility, and aging. Therefore, we have an aging population with epidemiological challenges that are typical of developing countries or developed countries. We also have risk factors such as sedentarism, tobacco use, overweight or obesity, an increase in NCDs, but also a very high burden of communicable diseases. So we have a double burden, which is a very important issue for healthcare. And we have bad quality of life linked to disability and dependency. So aging is not a problem in itself. However, we must assess it and address it to promote healthy lifestyles, to manage people's health and chronic diseases that are highly prevalent, such as sedentarism, etc., and to improve their autonomy and functioning to the extent possible and reduce dependency. So basically increase the quality of life. And this is key because we have a pretty bad Gini index, and so we have to focus on these issues. As far as the healthcare situation in our countries is a very simple chart, but we have hypertension, cardiovascular, overweight, obesity, cancer. It was the second cause of death in older adults, and sedentarism, 94%. So we have an aged population with issues of significant chronic disease. In terms of functionality, we can see that the majority of the people 65 and older are independent. About 82% of our older population is independent. We have about 400,000 older adults that have some degree of dependency, and that's where we need to focus a little bit on our healthcare services. The framework that we use for our national program is international framework that you can see on the left, and our national framework focuses on these stages: a comprehensive policy on positive aging, which was published back in 2012, our national health strategy, and the Better Adult government plan. And it was focused on older adults. And for the next decade, we want to have strategic actions on aging through our public aging policies and our national health care plan for older adults that will be aligned with our national plan, which is being developed. So our proposal is this document that has already been published. Like I said, it was developed by the Disease Control and Prevention Unit with input from the ministries and all the stakeholders, including the ministry and all of their units and divisions. The plan aims at preserving functionality, independence, and health. And some of the strategies are to have the social sanitary model with multi-morbidity, because older adults usually have pre-existing conditions. We strengthen comprehensive geriatric care, and we have Law 21168 that gives preferential attention to older adults. This is all part of our territorial country because we're a very long country and we have to get to everyone. Our national plan is summarized in this conceptual framework, and it has 6 strategic lines of action. One is education, promotion, and prevention. The other one, service provision, which has to do with equipment and infrastructure. Line of action 3, strengthening the comprehensive network of care to older adults. Then strengthening our information systems, which is very important for us to have reliable information that can be managed. And then everything that has to do with regulation and oversight, technical standards, rules, etc. And of course, we have funding on the top. And as part of the approaches in the plan, we have social determinants of health, we have rights, life course, gender, interculturality, etc. So these are cross-cutting themes. Now, in summary, the proposal, which is in this document that's pretty long, can be shown here. There's areas and objectives. Each area is tied to certain overall objectives that are broken down by line of action. And you can go to the process indicator, which is the last one. In order to stick to the allotted time, as far as the summary of initiatives, I'm going to click on the link. So you can click on the link and you can see the objective, the proposed strategy, initiatives, actions, and expected outcomes with an indicator and a goal. This is how each one of the proposals are broken down for in each of the areas that have a long-term proposal. Here, for example, we are focusing on developing a document to redraft the supplementary nutrition program. So it says what we're going to do, how, and what the expected outcome is in the long term. Each one of these lines of action and expected outcomes must be reported and be linked to the national plan, because that's what we're going to be monitoring. Then I can click on backs and we can see the same thing. All this text is hyperlinked. Here is on Alzheimer. This is from a couple of years ago. We have the indicators, goals, and then comments. And so that is how you can access to the plan. Then, for example, strengthening intensive healthcare for older adults, service provision. And so you can see all the information to the right until you get to the goal, which in this case is increase the number of regions that have specialized geriatric coverage and so on and so forth. I'm going to show you one more. This has to do with comprehensive visits for older adults and digital platform for older adults. So here we have in the card which is to have implemented digital options. And this is for October 2023. So these are longer term because our national plan focuses on a 10-year timeline. So very briefly, I wanted to tell you that just like with the other previous presenters, we had to divert our attention from our national plan, which was developed, in a very orderly manner, but we had to sidestep and address the pandemic. So we had to work very hard in developing documents and recommendations for the intersectoral work in order to address the pandemic. We had tons of documents that we've had to publish in order to help. For example, recommendations for caregivers, COVID-related protocols, how to care for COVID patients, etc. We had tons of documents that we published. They are all available in our Ministry of Health website. This may be useful for everybody. Also, all kinds of strategy, for chronic diseases in older adults, etc. So another document, a healthy mind, which is the middle one, and then 30 days to exercise your memory. So we put a lot of effort, and all of this was aligned with a plan because all this is part of a national plan. We can share these documents if you need them because, like I said, it has been published already, and I'm going to stop sharing right now. But anyways, we can share the documents with you if you need them. This concludes my presentation. I don't know if I went over my time.
Doctora, muchas gracias.
You did wonderful, doctor. Thank you.
Muchas gracias por la presentación.
Thank you very much for the presentation. Now to close today's session and share the last words with you from the perspective of the region on these topics and future activities, I now give the floor to Enrique Vega, who is in the Healthy Aging Program at PAHO headquarters in Washington, D.C. I'm not going to speak that much, but I simply want to thank all of the participants and panelists for participating in this first webinar. This is part of a webinar series we're going to have over the course of September and October to celebrate the launching of the Decade on Healthy Aging, and also trying to bring in particularly important topics to be able to carry out our work over the coming 10 years. We particularly appreciate your work of cooperation and integration and learning from each other's experiences with health systems throughout the region, and particularly in terms of ageism. We thought it was important to start with this topic because age-based discrimination continues to be apparent in the work of our health services organizations, our health systems, and daily clinical work. So we need to begin to work on this. First, we need to make clear what these practices are and to enhance the capacity of our human resources by training and educating them to work on this, and also to therefore bring about transformations and redesign the capacity of our health system that allows us to more clearly align with the needs of older persons. As Patricia said, this seminar has been recorded, and the next webinar we are going to hold is the launching of the decade of healthy aging next week. And what we're going to do is look at all of the experiences we've discussed today. We want to make sure this is clearly reflected on the platform so that we can take advantage of exchanges amongst our professionals, our technical people, and with the essential participation of older persons, their families, and the community. Once again, on behalf of PAHO and the Family and Life Course Promotion Unit, Healthy Life Course, Family Health Promotion and Life Course. I want to thank you for your participation, and we'll see you next time. I think we're closing on time, right? Thank you very much. Thank you, everyone, says Patricia. Bye, and thank you. Bye, greeting.
Saludos.
Saludos.
Muchas gracias.